So with respect to the current state of breast cancer in Australia, it affects about 1 in 7 women. And what has been observed is that there has been a 30% increase in breast cancer over the past decade. Now, this is attributable to a number of reasons, including better screening. Digital mammography has certainly increased the sensitivity and the pickup rate. There is more awareness in the population, and we're achieving rates of greater than 60% of the population participating in breast screening, as well as the trend observed internationally towards an ageing population. The majority of women are over the age of 60 at diagnosis. However, we know that it affects all age groups, including 1 in 600 men in their lifetime. The strongest risk factors for breast cancer are gender, age, and family history. Hormonal factors include early age of menarche, late menopause, hormone replacement therapy, and nulliparity. There are lifestyle-related factors as well that contribute to risk, including smoking, alcohol intake, and low physical activity. And I've defined the next two features as patient-related factors. They're really intrinsic to the patient, including BMI, so high BMI, and extremely dense breasts. There are breast assessment strategies related to whether the patient is asymptomatic or symptomatic. In asymptomatic patients, they attend breast screen for assessment. And women over the age of 40 are welcome to participate in this. However, they are invited from the age of 50. There are different screening regimens according to risk stratification, which is informed by the family history. Patients at average risk are advised to have a mammogram every 2 years. Patients at medium or high risk may include annual mammography supplemented by ultrasound with or without screening MRI. For those patients who are symptomatic, they must undergo the triple assessment, which involves clinical, imaging, and biopsy. And this has not changed. The clinical being defined as history and physical examination, imaging being defined as a mammogram in all patients over the age of 30, and ultrasound imaging of the breast. Biopsies, definitely core biopsy is preferred where possible. If not, a fine needle aspiration biopsy will suffice. The breast cancer treatments available today include surgery. I will be going through the surgical options in more detail. So I'll discuss radiation therapy, and interestingly, it includes whole breast radiation therapy with a boost to where the tumour bed was, but also some patients are having partial breast radiotherapy, which means that the radiation therapy is being targeted to the tumour bed. In patients who have mastectomy with advanced disease, or early breast cancer of a certain size at the time of surgery and presentation, they will have radiation therapy to the chest wall. And there's always a consideration with respect to radiation therapy to the nodal basins. So that includes the axilla, supraclavicular fossa, as well as the internal mammary chain. Systemic therapy today has expanded. It includes not only chemotherapy, but also targeted therapies such as Herceptin and immunotherapies such as PARP inhibitors. Systemic therapy includes endocrine therapy, which is our tamoxifens and letrozoles. If we take all stages of breast cancer, the overall 5-year survival rate in Australia is 92%. For patients with early breast cancer, it's up to 98 to 99%. Now, what we need to acknowledge in determining treatment pathways nowadays is that the diagnosis of breast cancer is actually heterogeneous. I've listed here what a conclusion of a pathology report may include. And what you will note is that it may include invasive cancer, it may include non-invasive cancer, defined by ductal carcinoma in situ. Within invasive cancer, the grade may vary. The ER, PR, and HER2 receptor statuses may vary, and the Ki-67 percentage may be vastly different. We'll explore what all of those mean. So does it mean we know that these differences exist? Are each of these pathologies treated in the same way? Now, I'm sure you would say this is a leading question, but it's a good segue into the current treatment pathways for breast cancer. And in order to understand the current treatment pathways for breast cancer, it's about really appreciating what is the definition of tumour subtype. This is now what is defining breast cancer, and tumour subtypes in breast cancer are based on the receptor status, which is defined by the estrogen receptor, progesterone receptor, and HER2 expression. They are resulted as being positive or negative. The Ki-67, which is a representation of the degree of mitotic activity, and the grade, which refers to how abnormal the cells are compared to a normal cell. So grade 1 is that it's not that abnormal. Grade 3 is that it's really bizarrely abnormal. So when we take those factors into account, we can stratify breast cancer with respect to 4 different subtypes. Triple negative, regardless of grade or Ki-67, is always defined by the receptor status. It means that ER, PR, and HER2 is negative. HER2 enriched, regardless of the grade, Ki-67, or the ER or PR status, refers to all cancers that are HER2 positive. Luminal A and luminal B actually take into account all factors. In these 2 subtypes, the HER2 is negative and the ER and the PR is positive. However, luminal A refers to a lower grade cancer and a low Ki-67, whereas luminal B refers to a higher grade cancer like the grade 2s and 3s and a higher Ki-67, being more than 25%. So what does this imply with respect to the treatment pathways? Well, if a subtype is characterised as triple negative, standard of care is that if it's more than 6 millimetres in size, systemic therapy is recommended first. Chemotherapy with or without immunotherapy these days. The patient then proceeds to surgery, and in the setting of lumpectomy or where it's indicated after mastectomy, we'll have radiation therapy. If it's a HER2-enriched breast cancer, again, if it's more than 8 to 12 millimetres in size, systemic therapy is indicated. This is mainly targeted therapy, Herceptin supplemented by chemotherapy. The patient then proceeds to surgery and again may have radiation therapy if they choose lumpectomy or if it's indicated after mastectomy, with or without systemic therapy. So what that means is that there are some patients who may be eligible for a second-line systemic therapy. And that's another form of targeted therapy, but that is only eligible on the PBS if they have the neoadjuvant systemic therapy first before surgery, because the indication for that second-line therapy is informed by the final pathology on the surgery after neoadjuvant systemic therapy. If the patient also has ER/PR positive disease, then they'll have endocrine therapy as well. Luminal A breast cancer is always surgery. We now have a trial looking at whether surgery after some genetic testing on the final pathology will stratify patients into benefits towards just radiation therapy or just systemic therapy, and we look forward to the results of that trial. Luminal B breast cancer is a mishmash of possible pathways, and that's because it is known to be a little bit resistant to systemic therapy. So it may include surgery first, then radiation therapy, systemic therapy, or the complete opposite, or somewhere in between where there's systemic therapy, surgery, then radiation therapy. So the take-home message from this slide is that there is not just one treatment pathway. It can include many different combinations for a patient with a diagnosis of breast cancer. I wanted to also highlight that there is a difference between invasive and non-invasive cancer. For ductal carcinoma in situ, the treatment pathway is established as surgery with or without radiation therapy, which is informed by the size and the tumour margins on resection. But is it as simple as tumour subtype determining the treatment pathway? No. Tumour subtype plays a really large role, but it is also informed by the goals of the patient with respect to how motivated they are, that they really want to try to achieve breast conservation surgery and steer clear of mastectomy. The general well-being of the patient with respect to comorbidities and their resilience with withstanding the effects of chemotherapy or systemic treatments, as well as the assessment of the multidisciplinary team. And in the future, I'm sure over the next 10 years, this space will evolve even further as there's emerging evidence from clinical trials. So this is a dynamic area, and I'm so pleased that you're participating in this CPD, because I'm sure it will change in the future as well as we learn more about the effective treatments. So what is currently discussed with patients at the first consultation with the breast surgeon? Well, at the first consultation, the mainstays do still exist: the history and examination, imaging and biopsy, but there's certain nuances that have changed. With respect to history and examination, breast health, general health and comorbidities, it includes the goals of the patient, but also the breast phenotype, which means the breast size and shape, as well as the tumour phenotype, meaning the tumour size and location as well. And also from obtaining a really detailed family history, determining the need for genetic testing. A review of the imaging and assessment is undertaken, as well as a need for any further imaging, which these days includes a consideration towards MRI, PET scan as a means of staging, which is supplanting CT and whole body bone scan for certain tumour subtypes, as well as a review of biopsy results and the need for any other further biopsies, such as other lesions in the breast or an abnormal lymph node in the axilla. And then there's a discussion of the options, and it's not just about the surgical options now, but also the treatment pathways that are available. And the standard of care today includes an MDT discussion pre-operatively as well.